And in this video, as the trial of the nurse Lucy Letby nears its conclusion, the jury now hear from the judge and his final summing up of the case against Lucy Letby. The trial judge now refers to the case of twin boys Child E and Child F, dealing with Child E first. Both twins were born in good condition, the jury is told. Child E died less than 6 days later. The court had been told Child E was very premature. A doctor agreed Child E was capable of dramatic changes in his condition. The day after Child E was born, the mother went to cuddle Child E as he was on CPAP breathing support. On July 30th, the boys were progressing really well, and due to a high blood glucose level, Child E was given a low dose of insulin. The twins were doing well and stable on August 1st, with time out of his incubator. On the day of August 3rd, a nurse said the mother was on the unit with long periods of skin-to-skin contact and Child E could have as many cuddles as he liked. Child E was pink and well perfused with regular circulatory system and a cautious feeding regime. Everything remained well. Intravenous caffeine was given as prescribed. The judge says Dr. Emily Thomas had examined Child E and there were no signs he was unwell. Observations were normal with a soft non-distended abdomen and no suspicious aspirates. He was, quote, well and stable. A nurse noted Child E's blood sugar was higher than normal and his insulin infusion was restarted at a lower dose. Antibiotics were given as prescribed. A doctor said the observations were normal and not a cause for concern. The high blood sugar level was relatively normal for a neonate and would not lead to the sort of collapse seen hours later. Child E's mother recalled giving cares to Child E, then going upstairs to provide milk between 7 to 8:30 p.m, the latter being the time of the night shift handover. Letby was the designated nurse for Child E and Child F in room 1. Letby said the 9 p.m. feed was omitted because of 16ml mucky bile-stained aspirate. This was discarded and the SHO was informed, told to omit the feed. She said the doctor's name was not always made on nursing notes. Child E's mother recalled going to see Child E and Child F at 9 p.m. Letby was there at the workstation, the mother said, and she added Child E was crying like nothing before. It was, quote, horrendous. She saw blood coming out of his mouth. It was not on or going onto anything like a dribble pattern. It was blood. It was smudged and didn't look completely dry. It was darker than normal. The mother said she was panicked and asked Letby why Child E was bleeding. She said Letby said that NGT had been rubbing at the back of the throat. Letby did not recall saying this. In cross-examination, she said she did not tell the mother this and would not tell parents to go away. She accepted that in interview for Child N, she had said an NGT could cause bleeding. The mother said she accepted what Letby had said and did as she was told to go back to the postnatal ward as Letby was an authority figure. But she was concerned. She said she made a call to Child E's father. The judge refers to phone call data at 9:11 p.m. The father said the mother was upset at the time of this call. Midwife Susan Brooks recalled Child E's mother had said to let her know if there were any updates overnight from the unit as one of the twins had deteriorated slightly. She had recalled at 11:30 p.m. the neonatal unit rang to bring Child E's mother to the unit in 30 minutes as Child E had a bleed. Letby said in police interview she could not recall the events with Child E's mother and could not remember any specific bleed. She said the 14ml bleed later, after 10 p.m, was very concerning, and in evidence that was when she first saw bleeding on Child E. The judge says there are significant conflicts between Letby's evidence and that of the parents. He says the defence say the mother's evidence is unreliable in relation to timings. The judge says Dr. David Harkness noted at 11:40 p.m. Child E had a desaturation with colour changes on the abdomen, quote, a strange pattern over the tummy which didn't fit with poor perfusion. The legs and upper arms were pink in normal colour. He said the only other time he had seen this was with child A, and not since. The patches were 1 to 2 centimetres big, and he carried out an emergency intubation. Letby said there was a purple block on the abdomen for child E at 11:40 p.m. She said it was not like Dr. Harkness had described. She said she found child E's death very traumatic and filled in a Datix form. She said the medical team were late administering a blood transfusion. The defence challenged the decision not to give a blood transfusion earlier. A doctor had said she did not believe the collapse was due to blood loss and that blood transfusion had its own risks. She said she did not believe, even with hindsight, child E should have had a blood transfusion at that point. The mother had contact with Letby after child E died. She said Letby bathed child E. In Letby's evidence, she said the parents bathed child E. A doctor said at the time she believed child E had died of NEC and that a post-mortem examination would not tell the parents any more and would delay their transfer back home. She had said NEC was the most likely cause of the gastrointestinal bleed. No post-mortem examination was carried out. She completely agreed that with hindsight she should have requested a post-mortem examination. She apologised to the parents for not pushing for that, having wanted to avoid further distress for them. Letby said in messaging with colleague Jennifer Jones-Key in response to the unit being on a terrible run that child E had had a hemorrhage and could have happened to anyone. She said the searches for the parents of child E and child F more than once on Facebook was part of a normal pattern of behaviour for her, as was taking a picture of the sympathy card she sent to the parents. She said it was something for her to remember, as was a photo of her shift pattern. The judge says Professor Arthur said there was no evidence on the radiograph image for child E of an air embolus, but that did not exclude it may have happened. He said there were no features of NEC on the X-ray. Professor Sally Kinsey said child E did not have a blood clotting problem. Dr. Evans said child E was incredibly stable, at increased risk of NEC but suitably treated. He said if a baby had NEC, they would become gradually unwell, and child E would not have coped with handling in any way. The abdomen would have been distended, along with other observations. He said NEC was not a viable explanation. Dr. Evans said there was a significant hemorrhage and something must have caused this. He noted the unusual discoloration, which prior to this case he had only seen in literature as evidence of an air embolus. He said there must have been some sort of trauma caused by a piece of equipment, such as an introducer. He said there was no innocent explanation for it. He said he has never seen an ulcer cause this type of bleed. He said the hemorrhage was caused by trauma. Dr. Bowen says she formed her own opinion on the case and refuted going along with Dr. Evans' conclusions. She said the decision not to hold a post-mortem examination was a poor one. Dr. Bowen said babies with NEC do not go from being well 1 minute to very unwell the next. The 16ml aspirate before the 9 p.m. feed struck her as being odd and did not match child E's clinical picture at that point. She was at a loss to describe where that had come from. She said the NGT insertion can sometimes cause very minor bleeding in a baby, but not a hemorrhage. The blood vomit was an extremely unusual feature. Dr. Bowen had never seen a baby have a gastric hemorrhage in this way, the court is told. She believed child E died of an air embolus. The judge now refers to the case of child F. On July 31st, 2015, child F was given a dose of insulin to treat high blood sugar levels and he stabilised. On the day of August 3rd, other than a minor respiratory issue when child F was taken off CPAP, all was well and he was tolerating feeds. The prosecution alleged child F was given insulin via a nutrition bag on August 4th to 5th, and that the next bag hung up on noon on August 5th, a stock bag from the fridge, had a similar amount of insulin put in it. The jury is reminded of the relationship between insulin and insulin C peptide levels naturally occurring in the body, and the relationship between those two in synthetic insulin. A new TPN fluid nutrition bag was hung up at 12:25 am on August 5th for child F. Yvonne Griffiths said the fridge contains stock bags and insulin. That fridge was kept locked with one set of keys, initially in the hands of the shift leader, but available on request. There was no system for signing the keys in or out. Child F was the only baby on that night shift of August 4th to 5th who was receiving TPN. Professor Peter Hindmarsh says the bag administered at 12:25 am had insulin in. Dr. Harkness attended the unit that night and noted child F had vomits and was tachycardic with a heart rate of 200 beats per minute, but otherwise well. Professor Hindmarsh said these were signs of hypoglycemia. Doses of dextrose and salt water were administered. Kate Bissell and Band 4 nurses said they had never added anything to a TPN bag. Dr. Gibbs said the fall in child F's blood sugar level was unexpected. At 10:30 am, a new long line was to be inserted in child F as instructed by Dr. Solardi, with the removal of the old one. The fluids were stopped while the line was replaced and child F's blood sugar level rose. A new TPN bag from the stock bags in the fridge, of which there are about 5, was hung up at noon and fluids resumed. Child F's blood sugar levels remained low in the afternoon after dextrose boluses at 3 pm and 5 pm. The TPN bag was stopped at 7 pm. The judge details how the insulin blood sample was taken to the laboratory in Liverpool and analysed, and the results came back showing an undetectable level of insulin C peptide compared to a high level of insulin. It was suggested that the sample be referred for further tests, but child F had recovered by this stage, so the sample was stored for 7 days before being disposed of. Professor Hindmarsh said the increased blood sugar readings for child F during the afternoon were consistent with them following fresh bolus administrations of dextrose. The blood glucose had started to rise spontaneously between 10:30 to noon, Professor Hindmarsh said, during the time the fluids were not being administered. He said the dangers of low blood sugar include confusion, seizures, brain damage and in serious cases, death. The judge says the court has heard the most likely cause of insulin administration was for it to be administered intravenously. Professor Hindmarsh says the most likely way for this was via an infusion at a rate of 1.2 units per hour and calculated that 0.6 ml of insulin, a clear fluid, was added. He says the same amount would have been needed to have been added to the stock bag. He concluded that the only explanation was for child F to have received bags contaminated with insulin. Dr. Evans concluded child F had received insulin via the TPN bag. Dr. Bowen agreed and said 2 bags must have been contaminated with insulin. When interviewed, Letby remembered child F as the surviving twin of child E. She agreed her signature was for a TPN bag and could not remember if she had administered the TPN or not. The bags were kept at the top of the fridge, the insulin at the bottom. Letby said medication would not be added to a TPN bag. She agreed the blood sugar level for child F at 1:54 am was, quote, dangerously low, and denied harming child F or giving him any insulin. Letby, in evidence, said she believed her nursing colleague had hung up the TPN bag. She confirmed she did not know about C-peptide at that time. She knew adding insulin was life-threatening to a child like child F. She said Facebook searches for the parents was because the twins were on her mind. The judge now refers to the case of child G. Child G was born in a tertiary unit and was very premature, weighing just under 1 pound 3 ounces. She was at the margins of survival when born. On August 13th, child G was transferred to the Countess of Chester Hospital and was stable. Letby said she remembered child G, who had a lot of problems. The prosecution case is Letby deliberately overfed child G. Dr. Stephen Breary first reviewed child G on August 22nd, and the general trend was one of improvement for the baby girl. She was stable and well, with desaturation self-correcting. The oxygen requirement was continuing to come down. For September 6th to 7th, the night shift, child G was the only baby in room 2 and Letby had a baby in room 1. The prosecution case is after the 2 a.m. feed for child G, administered by a colleague, Letby deliberately injected milk and air afterwards. September 7th, 2015 was child G's 100th day of life, and a banner was prepared to celebrate that on the unit. Child G was still on nasal prongs and some oxygen, but was stable. A nurse said she usually completed the chart after the feed. The 2 a.m. 45ml feed was given via an NGT. Letby agreed the readings were good at this time. The nurse said an aspirate was taken from child G for a pH check, this level being 4. She then went on her break, and when she returned, she found child G had deteriorated with a projectile vomit. The deterioration had come as a surprise to her. Shift leader Elsa Simpson said she was at the nursing station with Letby when she heard child G vomit. When they went over, the alarm for child G went off. There was a large amount of milk and the vomit was on the cot, on the floor and on the chair adjacent to the cot. Respiratory support was given via Neopuff. Letby had said in evidence she had no contact with child G prior to the vomiting episode. She said she was aware child G had a lot of ongoing issues, but the observations were good up to that 2 a.m. feed. She said she had been with Elsa Simpson when they heard child G vomit and the alarm had gone off. She said when they arrived, no one else was in there. She said they immediately started to give child G Neopuff. She identified a possible problem of the nursing colleague overfeeding child G, but did not believe that to be likely. In police interview, Letby said it was a shock regarding the deaths which transpired between June to September 2015, but didn't feel there was anything that needed to be looked into. She said the nursing colleague was on a break when the vomit happened. She said sometimes babies vomit, but did not often projectile vomit. She said when babies vomit they can take on air when gasping. She added she was not sure the cause of the air in child G's abdomen. In a separate police interview, Letby said child G had either received more than 45ml of milk or had undigested milk from a previous feed. She said it was an oversight from a previous interview that she had not mentioned the vomit going on the floor and the chair by the cot. Dr. Alison Ventris said the vomit had been reported to her. For a description of child G being in distress and the abdomen purple and distended, she could not recall if that was something she had seen or was told, and the same went for child G's watery stool and a subsequently improved abdomen. Dr. Ventris was then called urgently to theatre. She said by this time child G was looking better. She was called out of theatre before 3:30 a.m. as child G was apneic and had desaturated. It took 5 minutes for the saturations to pick back up. Child G went to room 1 and had a further profound desaturation. At the time of insertion of an ET tube, blood-stained fluid was noted beneath the vocal cords, which Dr. Ventris noted was unusual. Dr. Breary said he had not seen a projectile vomit in a preterm baby like child G. There was a further profound desaturation at 6:05 a.m. and a decision was made to reintubate child G. Quote, thick secretions ++ in the mouth and a blood clot in the breathing tube was noted. 100ml was then aspirated from the NG tube. Dr. Ventris said she was not sure it was air, as that was not documented. Dr. Breary took the 100ml reading to be fluid or milk. Letby's case, the judge says, is she did nothing wrong and did not falsify notes. She accepted air or milk could have been pushed from the feeding syringe into child G's throat. She denied doing so. Child G was readmitted to Arrow Park Hospital on September 8, 2015 with presumed sepsis. She was very unwell on arrival with severe hypertension. A radiograph, Professor Arthur said, was not a sign of NEC. The baby girl gradually improved to the point of returning to the Countess of Chester Hospital on September 16th. Dr. Evans said child G was compromised by receiving a large volume of air and milk, and this was not unique to babies. He proceeded on the basis the stomach of child G was empty prior to the 2 a.m. feed, and a pH reading of 4 was indicative of an empty stomach. He said babies fed by NGT do not vomit. He said child G suffered significant oxygen deprivation which caused irreversible brain damage. He concluded child G must have had more than 45 ml of milk. Challenged on this, he said this was the first case he looked at and reached his conclusion without looking at any other cases. Dr. Bowen said the vomit was extraordinary and said it was impossible to say how big child G's stomach was, but the excess volume of milk would not be much to compromise the lungs. She detailed a number of desaturations and events for child G in June to July 2015. She concluded that it was clear by September 7th child G was tolerating feeds. A pH reading of 4 was not consistent with there being a large amount of undigested milk in the stomach. She said if there was, the milk would have neutralised the pH reading to 7. She concluded child G's stomach was empty. It was put to Dr. Bowen that she was modifying her opinion based on the accounts of the nurse and Dr. Evans. She refuted that and said she based the level of milk on the pH reading, not anything Dr. Evans had said. She concluded child G must have had a large amount of milk and air administered after the 2 a.m. feed. The judge refers to the events on September 21st for child G during the day shift at 10:20 a.m. and 3:40 p.m. Child G was, the court is told, in a satisfactory condition. He says there was an event at 10:20 a.m, had 2 projectile vomits and went apneic, colour loss and desaturation to 30%. Letby, the designated nurse, said she remembered the incident, and child G was due to receive immunisations. The event had happened after a 40 ml feed at 10:15 a.m. Child G was being treated as a term baby. Dr. Peter Fleming recorded the projectile vomits and that child G went apneic for 6 to 10 seconds. He discussed the case with Dr. Rachel Chang, and the course was to leave the NGT on free drainage as the abdomen was distended. Child G was to be transferred to room 1. Care had been transferred to a nursing colleague on September 21st. She said child G's heart rate was high when she took over, but had settled by 12:45 p.m. After the vomits, child G was nil by mouth. Dr. Chang noted child G was pale and had a feed delayed, and the baby was not herself. The tummy was soft and distended, so a screen for sepsis was planned. Child G needed to be cannulated, and this required 7 attempts, successful on the 7th attempt by Dr. Gibbs, by which time child G had been without fluids for 6 hours. A nursing colleague remembered Dr. Harkness and Dr. Gibbs arriving and believed child G was behind screens and on a trolley. She said when the doctors finished the procedure they would let a nurse know and the baby would be put in the cot. She next saw child G when Letby called her for help. She saw Letby providing breathing support for child G, and the nurse could see child G was a poor colour. The monitor was switched off. She shouted for nurse Caroline Bennion, and child G responded to treatment and was transferred to room 1. Child G was placed in an incubator. Letby, in evidence, said screens were put up for the procedure for child G. She said it was common practice for nurses to look behind screens, and said she saw child G behind the screen, alone, on a trolley, blue and not breathing, and the monitor was switched off. She said she was keen to put a Datix form about the incident. She said she did not take it further, as the nursing colleague said the situation was in hand. She said in police interview it was bad practice for the monitor to be switched off, and somebody had made a mistake in leaving child G unattended behind screens on a trolley with the monitor off. She did not remember making numerous searches for child G's mother on Facebook. Dr. Gibbs accepted the monitor should not have been switched off. He admitted he had no recollection after the cannulation, and accepted it was possible, and if a nurse said it had happened, then it happened, and he apologised for doing so. Dr. Harkness said he did not recall the monitor being detached, and would probably have told a nurse when they were finished. He said it was possible child G was behind a screen unattended. Caroline Bennion recalled child G needed to be cannulated. Arian Powell had no recollection of anything untoward clinically being brought to her attention. The prosecution say Letby was incorrect when she messaged a colleague to say Child G looked rubbish when she took over care for her that morning. Letby accepted she made an error on recalling the timing of the vomit, but said Child G looked pale on handover. Dr. Evans said he had 4,000 pages of material for Child G alone and concluded the episode of projectile vomiting was life-threatening and said Child G had been given far more milk than intended, more than 40 ml. He accepted the events on September 21st were not as serious as those on September 7th. Dr. Bowen said the feeds didn't add up, and the events of September the 21st were strikingly similar to September 7th, but the consequences were not as serious for the September 21st event. Professor Arthurs said if a baby had been deliberately overfed, that would not necessarily show up on an X-ray.